So this is a case of factor 11 deficiency in a 91-year-old patient. The patient is admitted under urology. The urology registrar contacted us because the patient has deranged coagulation profile. The APTT is 93 seconds, and the patient is admitted with them because of the bladder cancer and ongoing hematuria. They want to operate on the patient for the bladder cancer. The past history of the patient includes an STEMI a week ago. So now the question for hematology was whether this is an acquired condition or a congenital condition, because the previous blood test of the patients are normal. This patient has a background of cabbage 20 years ago and cholecystectomy at the same time as well, but they were uncomplicated. The patient does not have a history of bleeding disorders. Family history is normal, but his APTT is prolonged this time. So we did the mixing study for the patient, which comes out as prolonged. So we did the intrinsic and extrinsic factors for the patient, which is normal in our hospital to do all these factors. But ideally, for the exam purpose, it should be the intrinsic factors only because the APTT is high. So we find out that the factor 11 level is 4, so which is the cause of prolonged APTT. The other background of the patient also include multiple myeloma. So we thought that this factor 11 deficiency is acquired and it is secondary to multiple myeloma. Now the question is that should we give this patient octaplas or factor 11 concentrate so that coagulation screen becomes normalized and the urology team operate on this patient. Now the problem here is that if we give him factor 11 concentrate carries a risk of thrombosis, and this patient has an STEMI event a week ago. The patient is most likely to clot again and may develop another STEMI. The second option is to give him octaplas. The octaplas volume according to the weight of the patient was 1.5 liter if you give it as 15 ml per kg, but the ejection fraction of the patient is just 25%, and it will overload the patient and risky for the patient. So we had a MDT discussion with the urology team and aesthetic team, and discussed delaying the surgery of the patient. So it was decided that we should give him a tiny dose of factor 11 concentrate just to boost the factor 11 up to 30 to help stopping the bleeding, and delaying the surgery till 3 months from now onwards. So the patient will get some time from the NSTEMI till the surgery. So the patient agreed, the urology team agreed, and aesthetics agreed, and we postponed the procedure of the patient. Then that would also tell us if we increase the factor 11 level for the patient up to 30, but the patient is still bleeding, it means this is the anatomical bleed, not related to the factor 11. Factor 11 is promoting the bleeding in this patient, but not the main cause of bleeding in this patient. So the patient is still under us, and we are observing him. Let's see what the factor 11 level is after receiving factor 11 concentrate. Please read about factor 11 concentrate and its thromogenic potential in a patient. And secondly, we do not give tranexamic acid with factor 11 concentrate because of the thromogenic risk. And because this is a urological bleed, so tranexamic acid is already contraindicated. Another condition where tranexamic acid is contraindicated is with fever. You don't give tranexamic acid and fever together because of the risk of thrombosis. So see you next time with another case.